know that because you
Comes Robin.
this room a lot.
A couple times.
Yes.
Hey, Robin.
Good morning.
Well, we will compromise here. According to the official clock, it's 1 minute after 9. According to the county clock, it's 1 minute before 9. So we'll call it even and start the meeting. Welcome to the CMH board meeting for Friday, August 22nd. We'll call the meeting to order. And the invocation this morning, I was thinking about one of my favorite verses from the Old Testament. The book of Proverbs is an interesting book. It's not biblical dogma. It's not deep theological treatises. It's observations of practical life. And one of my favorite verses I ran across in a paraphrased version was, if you don't want to hear the servants talking about you, don't listen at the kitchen door. Now that might seem a little unusual for opening a meeting, but it's an observation of human behavior. We're in the business of dealing with human behavior, personal relationships, interpersonal relationships. And along with that dynamic sometimes is the dynamic of roles of authority. And we don't always handle that well personally ourselves. Hopefully as an organization we do. And later in the agenda today, we'll be talking about the executive director's review. So you might keep that in mind. There's some lessons for us there. People are always going to have opinions about you. And they may not tell you to your face what they're thinking. If you really want to know what they're thinking, go listen at the kitchen door and hear what they're really saying about you. And that's sort of what we do in our review process for the executive director. So keep that in mind. Let's have a moment of prayer. Lord our God, creator of the world, we thank you for an opportunity to come here and serve you in this agency. We thank you for our dedicated staff of employees who try to carry out our mission and provide opportunities and encouragement to the residents of Ottawa County whom we serve. We pray that you bless our meeting, give us wisdom, give us patience, and give us charity to one another. As we ask it in Christ's name, amen.
Amen.
Join me if you can in standing for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Our mission statement and vision are included in the minutes for you. We'll open the floor for public comments at this point.
Good morning, Barbara Lee Van Horsen from the Momentum Center and the City of Grand Haven. September is a very busy month, so I wanted to make sure that you knew about a number of opportunities that we have that you can engage in. First, I'm really excited that we're starting something we're calling the Wellbeing Collective. We have a group of practitioners who are offering well-being practices like auricular acupuncture and energy work and reflexology and other things from 6 to 8 p.m. most days starting in September. We have a particular calendar just for that. So that comes out of our desire to try to reach more people. And it's an opportunity to just learn about those practices or to experience them. So excited to get that calendar rolling. We'll have an open house in October once we've worked out bugs through the first month. September is also Suicide Awareness Month. And so our movie night for our free dinner and movie night, we're going to be showing The Sun by Hugh Jackman. It's not a lighthearted movie. It's PG-13, but it's a very honest and direct look at teen suicide. So we're publishing that with trigger warnings, but I invite you to come and see that show. And then we have a follow-up town hall on September 29th which is focusing on parenting and mental health. Both the need to take care of and pay attention to our children's mental health, but also the toll that parenting can take on a parent's mental health. So we have a panelist of 7 experts from our community speaking, and then we'll have our community conversation around that. And then finally, I want to reiterate my invitation to you to experience Homecoming with a Heart, our fundraiser and social interaction event, which will take place at the Midtown Center in Holland on September 6th. Tickets are only $40, and we make sure that all of our members who want to attend are able to do that. So I invite you to experience any of those opportunities. Love to talk to you more about how we're approaching things and what we're doing and what we're achieving at the Momentum Center. So reach out to me anytime. Together, we'll keep gaining momentum.
Good morning. Sarah Lewikowski, Mosaic Counseling, and a resident of Spring Lake. I want to thank you again on the board, Dr. Brashears, for the county's mental health millage support, your dedication to mental wellness in Ottawa County. As a reminder, Mosaic Counseling is a nonprofit founded in 1978 in Grand Haven. We don't turn anyone away in Ottawa County. Anyone who lives or works or worships or attends school in Ottawa County, we will not turn them away for mental health services, professional counseling. We're accessible, affordable. Clients of any age are offered services regardless of insurance status. Our lowest copay is $6 or volunteer work. With a panel of 270 therapists, we have never had a wait list. So if you hear that people have to wait for months in Ottawa County to receive professional mental health services, that is not true. If they call Mosaic Counseling, we can get them right in, and if they're in crisis, we can get them in within a day. In fact, 90% of our clients that responded to an intake follow-up survey stated that within 2 weeks, they did make connections with their therapist. They'd either already seen them or had an appointment. Those who said they hadn't said, "Thank you for the reminder. I will call them right away." In addition to outpatient counseling for the mild to moderate, we also provide in-school therapy. We just finished our 16th school year in Ottawa County. We saw 229 students. They were offered free counseling in 29 schools throughout the county, and that comprised of over 3,000 sessions. These are students who it's the financial and transportation barrier that they're not going to be able to see a professional therapist. We also trained 351 students in QPR suicide prevention, and it is Suicide Prevention Month next month. And so we will be offering free QPR sessions throughout the county, and I will make sure that that is publicized. So if you ever want to attend one of those, it's only an hour, and it truly can help save lives. Evidence shows that early mental health intervention reduces medical, workplace, justice, educational, and public assistance burdens. And in a county the size of Ottawa County, roughly 300,000 residents, that actually can save a county $18 to $34 million in savings for all those different areas. And so early mental health intervention is happening at Mosaic Counseling. It's the easiest referral to make. As I always say, we are a nonprofit, but it is truly the easiest referral that you can make. And your investment is critical to the mental wellness of the county. And if you are ever interested in hearing more about Mosaic Counseling, I am always up for coffee, or you may come over to our office. Thank you very much for your time.
Thank you.
Good morning, Krista Mason with Benjamin's Hope. Wanted to give you a quick little update. We have now opened our 2 new homes and are over the next several months bringing in 12 new people, some from Ottawa, some from Allegan, some from Kent. We've got 3 new folks that have moved in and are settling in beautifully, and we're bringing on new staff. I've shared with a few of you, we need new staff. It takes about 30 new employees to open 2 new homes. Those new employees get dispersed around, mingled in with our experienced employees, but we're also always losing college students, some of our wonderful staff. So we did a new hire training earlier this week with 11 new employees, and I was so deeply encouraged by their heart to be part of life with the men and women of Ben's Hope. So thank you. Thank you. The difference this is making in these families' lives, these people's lives, is extraordinary. I'm so grateful.
Thank you. Any other comments? Do we have anyone online, Amanda? Okay. Then we will move on to the approval of the agenda for today.
Motion to approve the agenda.
Support.
Any comments or changes? Okay. All those in favor of the motion respond by saying aye.
Aye. Aye.
Pose same sign. Motion carries. We have consent items on the agenda today. There is a suggested motion would be to approve the items listed there, A, B, C, and D.
So moved.
Any discussion? Okay, then we'll call the vote for the consent items. Since we have contracts, it'd be roll call.
Yes.
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 Yes. Yes.
Yes. Yes. Yes. Yes. Yes.
Yes. Motion carries. Next up would be committee reports. Finance Committee, do we have a report from our chair?
Yes. As we met on Monday again, and you probably have already reviewed the service contracts that we approved. There were 11 that were amended or renewed. And then there were 4 that were new service contracts. And we talked about those as a group and reviewed them. Of course, we also reviewed the budget. And again, very happy to report that we're where we should be financially right now. Of course, with all the, the way the money comes in, it's never going to be reported. This is exactly where we are because we know there are some delays in some of the funding that comes in. And also July looked a little bit different in terms of percentage because there were 3 payroll periods in July, just how that fell. So if you see that percentage and are a little bit concerned, that's where that came in. Amy also reported that we will be starting the direct pay from the state in October. Where that really, how that will look in terms of our budget, honestly, I can't tell you. I'm sure Michael could share more about that if you guys are interested in that. And really, it also, the millage budget is very much on target to what we had planned. And we had a meaningful presentation from Bill Phelps on looking at the scorecard for our service providers. So there's some way of looking at it, and they have so many checks and balances. This is not by any means the only. This is just a way, kind of reporting to us where the agencies fall in terms of criteria that has been developed. And it's new, so it will be probably revised, but for right now, we're happy to hear that that has been worked on and got great reports on the agencies that we're working with. So I'm going to ask if there's anyone else from the committee who has anything to add to what I said today.
I'd just like to say that I think the provider scorecards are really helpful tool. that is continuing to develop, but it gives us a much easier way to handle the immense number of contracts that are out there. And so you can get a good look at where these folks are and know that there's been good due diligence amongst the staff and the leadership here in regards to recommendations. So, thank you.
That's pretty much it, unless you had, Tom, anything else to add?
Nope, thank you.
Okay.
Okay, actually, I would comment that when we set up the committee structure, the goal was to try to handle a lot of the nitty-gritty of reviews and discussion apart from the main board meeting. And, it's encouraging to see that the board members in general seem to be comfortable with that format, and hopefully it will streamline things going forward. The next item is the CEO's report. Michael?
Yeah, good morning. Just a point of clarification, when Vonnie was talking about the direct payment, she was talking about the state's change and how CCBHC revenue comes to us, that extra payment we get from the state. Until this October, it would go to the PHP or the regional entity, then to us. Starting this October, any CCBHC funded CMH, that direct payment will come from the state, not even involve the PHP at all, come right to the CMH. And we've been working for months to figure out how that's going to work with the state. Amy says that one of the advantages, and I told her I'd say this because she couldn't make it today, she's off, is that we'll get our payment quicker. We could literally submit to the state what our expenditures are and literally within the next month get the revenue, which will once and for all help us have a better predictor of how much money we actually have. When you look in the packet and you look at the budget and you look at CCBHC, there's a huge deficit number right now because we haven't received the revenue yet through the PHP. Now, different PHPs or regional entities in the state do this better in terms of quicker. So, but that would be a huge advantage to us, is to get extremely timely payments. Theoretically, we'll see if they do it, literally within weeks versus months. And sooner or later, I'll be able to actually tell the finance committee and this board of here's where we're actually at, instead of, well, this isn't 3 pay periods and project it out. And I thought we had a very good conversation at the finance committee about how we look at contracts and various other things. So if you haven't had a chance to watch that video, please do. But I just wanted to clarify, we were talking about CCBHC payments only coming directly from the state. And over this next year, I'll renew my educational series on the different funding sources, and we'll be able to update our educational presentation on CCBHC and have it in a recorded kind of format so that board members, the public, can remind themselves what the heck it is all the time.
Does the LRA did they take an administrative cut?
A
of that
small
money?
one,
Is the
yes.
state going to still take that as well?
So far, my understanding is no.
There you go. That's great.
Right. So, but with anything with MDHHS, we'll see, but that's what they're saying. But at least in this area, in terms of CCBHC and management, they're moving away from any PHP being part of that formula. I mean, there are pros and cons to that, but we're thinking on the positive side, trying to stay optimistic that we'll get quicker payment. And we've had a lot of direct, Anna, our COO, and Amy, our finance person, has had many discussions over the last several months with the state about where we should be at in terms of these extra payments. And so it's been nice to have that direct conversation versus having a middleman in that conversation, for sure. So that's what was being referred to. I wanted to make sure we weren't thinking all of the payment sources are going to come directly from the state. That would be 1996, when every CMH had a contract with the state of Michigan to manage Medicaid and general fund. In fact, I think we should go back to the future. If I had it my way with all of this, leads into some of my items here, the stuff with procurement, you want to eliminate a middleman, just eliminate it. There is nothing, just so the board understands, nothing that requires the existence of a PHP to manage the Medicaid system in Michigan. CMS prefers it, but we could have 0 PHPs if we wanted to. And Director Duff remembers the days when we directly managed all of the Medicaid for our local communities. And so I would suggest if you're going to reform the system, and you're not going to keep the existing system, which I think we could reform it, and I'm going to talk about reforming our existing system, then go to 0. Let the state do what it used to do. You know, the department used to come out every year with their team and audit us. They do all the same things the PHPs do now. They would manage, they would give direction and all the managed care functions that the PHPs do now. And they would do it in concert with local, community-based CMHs. So your CEO has been advocating, if you're gonna go this route, go to 0. Go back to, you know, someone's gonna wake up 5 years from now and say, you know what we need? County department, community mental health to serve the needs of their community in direct contract with the state for Medicaid and non-Medicaid services. Then we won't worry about how $22 trillion is spent on that level at all. That's the quickest way to get it back to the people and the providers, is to cut out that whole layer. If you're gonna reform it at all, I'm not in support of reducing the number to 3 and then cutting off the CMHs from direct partnership with that region. It defeats the whole purpose of community mental health. So to that end, I did have the ability to hold a couple of community meetings. One I had with the provider network discussing the state's procurement plan. Even though we had technical difficulties and I couldn't show some of the documents, we had a robust discussion about what we think it means, and really me listening to concerns that providers have in the current structure. And that went very well. That is something that you can, if you're interested, you can see that, you hear that discussion. We have it recorded and we'll make it available. I also did a Did You Know series on last Friday related to an update on the state's plan to restructure the mental health system at that managed care level. And if you get a chance to watch it, you'll notice that the way I presented it was more like there's a lot to still know. Here's what I think it means, but we're not sure. And we need to make sure that we're getting answers. Because I think in the past, I might have prejudged the plan to the point where it could scare the heck out of everybody. Like the end is near. So the end is not near here. CMHs have to exist regardless of what plan comes through. We are absolutely part of the community. Our role and function would be the things that we'd have to look at. So if you're a provider or a client of ours, a staff member of ours, a board member of ours, we're not going anywhere. What we do will be subject to review in terms of how we manage Medicaid, which is by far our largest funding source. So those are available. What's really cool is, like, you know, when we're doing those, you might have 20 people that are able on a Friday, because they do on Fridays, right? Watch it. But then we have like 100 people view it. And that's proven to be very helpful in being, for us, being as transparent as we can as an organization about information. But I'm going to make sure that I'm not over defining something that's still evolving. But I do think it's my duty to let people know of the potential pros and cons of any proposal, of where it's at, and not wait until we absolutely know. So just a couple highlights of that. If the state is, excuse me, it's not the state of Michigan, it's the Michigan Department of Health and Human Services. Other units of state government and other departments have nothing to do with this. So the Michigan Department of Health and Human Services, if their plan of procurement goes through, then we'll know exactly who is going to be the Medicaid manager in February. People have to submit an application, big, large organizations to do that. Now,
Michael, can I ask
Yeah.
a question here? A few years ago, was it Representative Shirkey or Senator Shirkey? Had a bill that was introduced trying to privatize the system. And the legislature was intimately involved in discussions about that. Presumably, they felt they had the authority to direct that process. It would have been implemented through MDHHS.
Correct.
but, Is the legislature totally out of the loop here, or do they not still have oversight of this?
so let's talk about that. The Shirkey bill, one thing I loved about it, completely transparent. Legislation, here's what it is, here's what we're trying to do based on feedback around. Introduce legislation to look at the restructuring of the mental health system. What was positive about that is that it was totally in the open. And it was a legislation action, if passed, would have informed the Michigan Department of Health and Human Services on how to look at management of the Medicaid system. Legislators are not out of the loop totally in this regard. They can influence, talk to the governor, talk to the department, ask questions, do that. But it's not a bill that's being passed. It's clearly simply in the mind of the department, one contract's expiring and we're opening it up for bids. So I would imagine legislators can introduce legislation about just about anything, including stopping A, B, and C. But during those previous efforts, it was a bill introduced for the world to see, to have a lot of communication about, a lot of advocacy on it. And even though I might have disagreed with certain elements of those bills, they were genuine efforts in the open. This approach, we haven't had one discussion as a CMH system with the state on why they want to do this. Besides what's published on the website, we are an extension of MDHHS doing the services in this county, in this region, and the department hasn't had one meeting to discuss it because their ideas, well, we're going with a new contract provider. This is what's been said. All of our attempts to have dialogue. I could talk to Senator Shirkey. I did during that time. I could talk to Mary Whiteford that had a bill. They were accessible. Legislators have been doing their job. Even with this current budget, they had their right appropriation, that they took the advice of it, right? So legislators can influence for sure, but this is a different avenue to get to system reform from the department's point of view, using the fiat of contract procurement, which is outside of usually the legislature. I don't know, those that work in the legislature, do I have that right? That makes sense to you?
Yeah, basically.
Yeah. So, I mean, they can always influence. What's needed to stop this is governor go to Elizabeth Hartel and say, cease and desist. That's the way to stop this. In lieu of that, there will be legal challenges to this. On the agenda, you'll say that we already have the Community Mental Health Association of Michigan asking each CMH member for a special assessment of money for legal costs to fight this. Just so you know, I got the request. I've sent it to county government because I don't believe that I can approve and have you approve an assessment of funds legally in this unless the county and the county commissioners are in agreement that they would like to engage in that type of activity. So I've sent the request to corporate counsel, the administrator, for consideration to talk to county commissioners of would the county engage in a lawsuit to stop this. I don't see any reason to bring that to you for approval if I need the county commissioner's approval. And if they don't want to engage in that, I can come back to this body and say, here's what we can do. So that's what that is on the agenda, that the Michigan Mental Health Association, our trade union basically, is asking for a special assessment of funds so that we can legally challenge the state's procurement process legally. I am not at liberty to divulge in this meeting the legal strategy. But once I get word from the county that they're okay with us entertaining, contributing, and participating in a lawsuit, then I will bring it to this board's approval as well. But I didn't think it was wise to have you go, yeah, do it, and then put us, there may be variables that we as a county and as a county department have that would not make it wise for us to participate in a certain type of legal action. So I'm working with corporate counsel, and if you're a county commissioner, this will end up being a discussion we're going to have and then come back to this group. Are you guys okay with that strategy? So I don't want you to vote on it and go, yeah, and the county goes, well, actually we can't because statute 5-6, whatever it is, says you can't, or whatever it is. If it would come from mental health funds. It would not come from county general funds. And we're not talking about a huge dollar amount. It would be the same amount of money that we pay for our dues every year. It'd be matching that. And I don't have the total, but it's not a giant dollar figure at all. But if you have 46 CMHs doing it and 10 PHPs, it helps. So in terms of an update on that, I'm keeping the community, the providers up to date. I will say that on September 5th, I'm going to have another Did You Know series. It's a Friday. It will be recorded on this issue, but I'm inviting Alan Bolter, who came to this body once before, who's second in charge at the Board Association, to give an update on procurement. So it isn't just Dr. Brashears giving an update by myself. I'm bringing other people that are involved in this to give their opinion and answer questions. And so Alan Bolter will be joining us on the Did You Know series on September 5th. It will be recorded, and it will be open for the public to view and our provider network to do, and he will be answering questions as well. And I'm going to start doing that when we have these statewide kind of initiatives. It's appropriate for me to give an update, but I'm going to bring other folks in to also talk about it. And, you know, I've already learned a couple of things in talking to Alan, like, oh, I might not have had this exactly right. It's really this. And so it's helpful to do that. So on September 5th, just for everybody to know, that's going to happen. I'm also putting together for next fiscal year, for our next year here, the topics for the Did You Know series in advance. And I'm going to go through the funding sources again, retake those original presentations because some of them weren't recorded, and update them based on the new information we have about all of the different funding sources we have. So that will go to the PQI subcommittee for approval because it's part of quality improvement and performance improvement, and then they'll be notified and sent to the board as part of that on that. One of the things that we're going to definitely do at the Performance Improvement and Quality Improvement Subcommittee, but annually here as well, is to kind of give you an organizational year in review. And so one of the things I asked our COO to do, Anna Bednarik, is to give me a couple of highlights. Let me just pull this up here. Of some internal things that we've been doing. And I emailed this, what I'm about to read off, to you this morning. And what I'm going to do with my director's report, I have many items with a lot of attachments. Later this afternoon, I'm going to go back to the office, make a recording, have the attachments, then send them out to your view, and we can add it to the public materials for this meeting. Instead of trying to spend an hour and a half going through those with you, I'm going to have a separate way of doing that. And then during this time, highlight some key elements, and then you'll either get the report before the meeting or after the meeting. Because I get long-winded, but I also write the same way. And you can end up having like 11 attachments. So I want to be able to, in a video style, point you to certain attachments and what they're doing. And then if you have questions, you can ask. So just so you know, that's coming later today. So one of the things we did is I have charged Anna, the Chief Operating Officer, with leading what I'm calling our organizational team. And it's the series of directors that we have in the various divisions coming together and making sure we have continuity of any organizational change or change in policy, procedure, or something we have to implement. And it was created to review and discuss the day-to-day operations of the organization. So over the last several months, Anna, under my charge and scope of the team, has dealt with a variety of issues that I just want to list to give you the type of stuff that we're dealing with internally so you get a snapshot and how we're managing the internal operations. In my director's reports, I talk a lot about what's happening externally from us to us. And you don't get a lot of information of the organizational change within CMH. So our performance improvement and quality improvement subcommittee will be a place where we bring a lot of that and then to the full board. Because that subcommittee's charge is to complete the code of the the mission of the mental health code to make sure that we're evaluating and providing quality services. So here's a couple of things that group has been working on over the last several months. One of the things is evaluating office space and coordinating the movement to staff to better suit needs. Looking at, we have any given day, you can walk over to James Street, our building, and you could think, Dr. Brashears, you're nuts. We don't need office space. We have a lot of empty cubicles. And I go, well, sometimes people are working remotely. In fact, if we had everybody that we have employed come at the same time, we wouldn't have enough physical space to seat them. So we're using remote work and as people to share space. And we're prioritizing our space for the clinical needs of our consumers. So this group, Operations Committee, is looking at that and finding ways for us to balance our space needs to give proper information to the county for future space needs. We've been told by the county we can't have any real capital improvement projects on our space until next year. So we want to gather that information. Our auto implementation, our new electronic medical record. This group is looking at the troubleshooting, pros and cons, and operational guidelines we need to have continuity amongst all of our programs and all of our locations. The counties engage in a wage study, looking at all of the wages of all county employees that were in it. And so this group was charged of looking at which they already did, get the information of the county and to help evaluate the impact when wage study results come back later in the fall here, probably in October. So I just want to know, we have a group that's designed to look at that. Determining agency communication platforms and how we manage communication. The Operations Committee is looking at that. We're involved at the regional level of we call them ROTES, like groups, that all the CMHs come together and we'll talk about finance, we'll talk about utilization management. This group is in charge of gathering that information and giving me an understanding of the organizational impact on regional entity decisions that are made. Millage operational guideline review and updates we do with this Operations Committee, or any policy and procedure update. This group looks at it to say, what's the impact to DD services, MI services, family services, contracts? Obviously, continuous budget review happens with this group. And the aforementioned provider scorecard was a result of the work of this group in the contracts department. They also do onboarding of performance improvement projects like Welcome to CMH and the onboarding process. It's a team there's a project going on about onboarding. It's a team including people from IT, finance, compliance, clinical departments have been working to streamline the onboarding process for CMH employees, interns, and contractual staff. This project that is overseen by the Operations Committee is working to automate onboarding and to ensure staff and supervisors are completing all required elements for new hires. We also have an auto implementation and change management team that's a subgroup of this group. So I'm just giving you a sense of the organizational structure we've put in place over the last year to streamline and to coordinate better all of our organizational change processes, and it's led by our COO under the scope that I've given her in constant communication back and forth. And it allows us to chew gum and walk at the same time, meaning I can deal with a lot of the external threats while we have a wonderful process of making sure that we're delivering services in the most efficient way internally. And it's the greatest charge I've given to the COO. It's not just she's a deputy to me and whatever I don't want to do. There's a distinct role and function of the COO under my guidance to ensure that we have the appropriate internal operational processes to be a center of excellence in the future. And I will tell you, I've been very happy with Anna Bednarik's response to this charge of giving her, because I'm often good at saying, here's what I want. I need a lot of people to say, here's how you specifically operationalize it and keep track of it. And that's what Anna is doing in partnership with my office. We're also just completed a Lakeshore Regional Entity Site Review. That's the region coming to us. The site review occurred in February, and it looked at 11 different standards. Each standard may include anywhere from 20 to 30 subsections that require documentation proof. I'm pleased to report, and I sent you in an email and will make available to the public, that we passed this thing with flying colors. In fact, most of the elements of the report, we met at 100% compliance. The lowest score we got in one element under this disclosure of ownership and control of clinical convictions for subcontractors, boy, we were at 95.5% compliance. Overall, we did not have any formal plan of correction items, but recommendations for improvement. This shows, in spite of the challenges we have had in terms of the lack of staffing and the lack of infrastructure that monitors compliance and our thing, meaning we don't have enough people, we're excelling to meet the requirement. You know, we're usually the first CMH the region does every year to do this. We ask, could we be not first this time around? So we're going to be second next year. But I'm proud to report, and through the efforts of the directors and the staff at CMH, that we overwhelmingly passed this regional entity review, which, by the way, the state used to do in 1996, just to put that back in there. Each standard may include up to 20 to 30 subsections, and so you can have like 300 or more elements that we're asked to be looked at. And the audit takes 4 days. It's a combination of record review, staff interview, all that kind of stuff. So as a CMH internally, we're starting to look at how operations run, how we coordinate operations. My first year that really concluded on the 30th of July, the first year was what's going on. It was like an assessment period, both internally and externally of CMH. What do we need to stabilize immediately? This year is how do we become more efficient? How do we be more excellent and high quality of services in a variety of areas? And so for the first time, I believe we can start an honest strategic planning process between me and the board with a collective stuff, because I allowed myself a full year to do a 360 evaluation from many variables. And you remember when I first got here, we did surveys, we collected information, what people's perspectives, we held some meetings. And I'm impatient and want to do things, but I'm really glad that I took a full year to get an understanding of what's going on. Because just because I used to work in the system and work in the system in a different role, you have to come back and understand the county dynamics, what's been going on internally, what are the issues of our contract providers, what are our families saying, what are our clients saying, how are we doing that? And now we're in the business and have the committee structure set up where we can start looking deeper and then get a better understanding of that. But in the PQI committee and the board, you're going to get more information on the internal organizational change that's going on, and not just the budget, not just external threats all the time, because you employ me to ensure that all of those internal operations are done. And I think one thing I notice in the committees is that we're building trust from a staff to the board because we're showing you the comprehensive methods that we're using. Where before we had to do that at the full board meeting. And so it's like, all right, well, how much information do you want to know? Like, we actually have 11 audits that we do. Yeah. And so board members were forced in a position to kind of go, well, do you even look at the thing? How do we even know the contract's legitimate? And so these conversations are helpful. Now, it's on the future agenda item here later, but I was asked to give a scope of each of those committees. And what I'm going to do, I'm going to recommend during that thing is that I have something written up. I'd like to give it to the executive committee of the board to review, and that they sanction it, get it the full board to look at the scope of these committees and make sure that we have that in our bylaws and how we're going to deal with changes to board structure. Our executive committee is supposed to look at it first and understanding how the process looks, and then we'll get it to the full board to say, yeah, it's within the scope of what we're thinking. So when we get to that agenda item, I'm going to report it. But I was talking about how information is disseminated. But I got to tell you, between our contract providers, our staff, and the hundreds, not dozens, of families that do self-directed care, I believe we're moving in the right direction to get more clarity in what we're supposed to do and challenge the way that we've been doing it to see if there's a better way. And we have a long way to go. But I feel like I'm at the back end of truly understanding the context. And we have a presentation today and other things. And that concludes what I was intending to talk about in my report, with the ability to add other items with descriptions in a report to come to you. And I'll take any questions.
Yeah, we have 11 audits. Are they duplicitous in any way? Like if you get CARF audited, could that eliminate another audit at some point? And is
Well,
there advocacy along?
Yeah,
these
so
lines?
when you talk about duplicative administrative burden, I think we've created a system that overachieves at it. Accreditation is different than the actual requirements of contractual requirements. Even though in a contract that we have says you must be accredited, the accreditation standards don't usually align with Medicaid standards. And so they're more like, this is the golden stamp that you're doing things. If there was an honest way to combine, say, CARF accreditation and the state requirements, it could be done and it should be done. But right now, our CMH is subjected to duplicative audits from multiple sources that look at almost identical information. And our service providers could have a contract with all 46 CMHs and all 10 PHPs, and we still do not have audit reciprocity in the system, which is one of the biggest complaints. And one of the reasons people say if you go less entities, you'll have less audits. Well, we'll see. But we do not have training reciprocity throughout the state. I can't take my training from one CMH and be guaranteed that it'll be accepted by another CMH if I move. Some regions do it better than others. So reciprocity and administrative duplicative burden is one of the major reasons people call for reform. It's my belief we could do it ourselves. The state could literally take the 10 regions, put them in a room and say, you have 30 days to do this, or guess what? We're going to make it a contract requirement. Instead, they do the opposite. You manage it, and we'll tell you if you're doing a good job. So all of the issues of duplicative audits could be resolved in the current structure by the state, in my opinion, mandating it. But no, we have multiple audits looking at the same, similar things all of the time. And it's one of the biggest reform items that we need, regardless of who's managing it in the state.
And it's costly.
Yeah. And you wouldn't run, I mean, if we were trying to set up a system to ensure that we're not uniform, we've done it, but it's not the PHP's fault. It's the lack of direction from the state. You shall do A, B, and C. We're like 10 little different systems of care that have similar guidelines, and how you implement those, it varies from place to place. And that's not fair for the Medicaid recipient. That's not fair for the citizen of Michigan. But it isn't the PHP's fault. I'm telling you that right now. They're given no guidance on the how. And so then you have to force existing organizations to get along. They have no legal relationship with each other. No. So I know it's a long-winded answer. I don't know any other way to do it, but I will tell you that duplicative of administrative audits and burden is the main clarion call on why people want things, one of the main reasons. And it has to be addressed officially one way or another. And I've given suggestions to the state and our region on how to do that within our current structure.
Thank you.
Michael, just to clarify
Mhm.
that, within our LRE, we have that same discord, right?
Correct.
Lack of standardization.
Yeah, well, and that's the CEO's fault in our region, all of us. We don't give our region enough authority to implement uniformity. In our bylaws, it requires a unanimous consent of the operations committee of the regional entity, which is comprised of the CEOs. Before in our bylaws, before I was there, it was not unanimous consent, but majority consent. So when the region has tried to step in, this is just my forensic evaluation being back in it a year, to say, we shall all do it the same, we're like, okay, until we don't like it. And then when we don't like it, we go back into our little tribes, all of us, and say, you know, we really shouldn't do that. We have given the regional entities so many double messages in the last 13 years, I can't even tell you. We had Beacon come in and they tried to streamline it and we said no. So what's the answer? The answer is being very clear what whoever manages the system on what managed care functions they will never delegate and ones they can delegate to us, and don't require unanimous decision-making among the CMH members to get a change in policy and procedure. And there is a way to reform what we have. But in our region, it's really been the inability for us CEOs, us, to agree and give clear authority to the region to make it a possibility. Now, in other regions, they have different bylaws and they have the opposite problem. CMH is like, we have no say, but there's a happy medium. Remember, under the mental health code, only CMHs can come together and form regional entities. Only we can do it. So we have to be members of it and help manage it. But what we have currently is Lakeshore Regional entity staff doing their darndest to create the best region we can without the ability to mandate anything. So until we get along at the CEO level and we all come together and look at that. Now, on the new state proposal, I'll be one of 33 CMHs in one region with 44 counties being represented. I'll have no voice. It will be the opposite. Like what I'm saying is modify our voice now. That creates no voice. I'll be a provider alone, just providing Medicaid services and not co-managing at all. Now that's subject to change. They could change what the requirements are with pressure, but the new model would make our situation worse, not better on that level. But I got to tell you, in my last year, I think this region's tried to do its darndest, all of us doing the best we can to create and administer a benefit that helps our folks when our whole region is so underfunded. It's not based on need. We don't have needs-based Medicaid funding. I mean, what are the needs of the people you're serving? What level of care are they in and having the money? It's strictly how many Medicaid lives you have. And this region gets hurt more than others. Some regions have a surplus every year. So that money gets moved around, hopefully at the end of the year. But our regional entity staff, I've been very impressed with what they've been trying to do in an environment that doesn't give them much authority. And right now, they're trying to figure out, will we be in existence in a year? Think about staff retention. So we're working closely with them to try to keep the system hanging on until we know what's next. Did that answer it, or did I get too much in the weeds?
Nope. Yeah, the other thing is, you had on the agenda here, millage.
Yes.
Did you want to discuss anything?
Yeah, we're starting our, and I've asked the COO, and one of our board members is kind of helping us here. We're starting to get together and look at the millage. We have to have the millage reform, not this August, renewed, not this August, but next. So we're bringing a group of people together, and then I'm doing it internally to say, what have been the benefits of the millage? Which programs have been in the millage, and what are the outcomes? What is the story of the millage? And that will come through this board. It will also come through performance and quality improvement. We have to demonstrate what we've done with the millage, how it's impact our community, and why would we renew it? And so we're starting at a group to look at all those outcome data and information that we have on millage programs. You heard one today for Mosaic counseling. If you remember last year, we approved one-time millage funding for certain projects, and Mosaic Counseling was one of them to help get mental health services for folks that we don't serve, that don't meet our criteria. And by the way, she's absolutely correct. The people can get in there really quick. They're using the same standards we are. Within 14 days, you get treatment, once you go there. And then we do that internally as well. But what that's about is beginning the journey with the board, with the community and letting people know what have we done with it and why renew it, and then creating advocacy to renew it. And we've talked to the sheriff's department, all kinds of different people. Last time, 10 years ago, our sheriff at the time was literally going door to door and saying, support the millage. But we have to make the case of what we've done with it and what we need it for in the future. And I'm just letting the board know, we're starting now. We're not going to wait until the middle of next year to start getting that information. So the intent of putting on the agenda is to know that that's happening. Last time we had the Friends of CMH, was like an external group that would help educate, kind of getting that started again. But my task is to say, what have we used it for? Has it made a difference? And are there changes in the way we are planning to use millage in the future? And what happens at the state level will influence that. So over the next couple months, we're doing that. But it's time to start looking at it honestly, and then building in quarterly updates on millage spending and millage program efficacy. The citizens of Ottawa County needs to know what they approved, right? So it's just to remind the board and to tell them we're doing that. But it's my long-term intent that quarterly at the PQ&I committee and other committees, we'll have an update on how millage programs are doing. And are they making a difference? All of our millage programs. And the review of the data of that. So that's what that's intended to do, is to get that initiative launched.
Can I ask something?
Please.
When you provide the millage, are there provisions that need to be met?
Mhm.
So everybody that's given the millage has,
Yes, and contract requirements, and
and that's
data.
followed up on?
Yes, and data analysis of that. And we're finding that our contracts with millage programs are sometimes too general or too specific. So we have to kind of go back and look at those requirements. And that's going to be working with the providers to say, all right, what information you think is good or not? Like one of the things we added, say for social rec programs, is of those that attend social rec programs, is this a preventative factor in crisis contacts or maybe going into the hospital? Is it this? And what we're finding, we just got the initial result, is overwhelmingly yes. But looking at the percentage of people that go to, say, social rec that are already CMH clients, or the percentage of people that are not CMH clients, and what's the balance of that? So we're looking at that data now, and what's the impact to the community, right? And then what other things do we need to look at? I'm interested in all our millage programs, all of them, not just social rec, on what is the cost per person to do that. So it's good that we offer a program, but say a program doesn't have a lot of participants in it and we're sending them a large amount of money, do we want to spend per person this amount, where in traditional mental health services, we don't even come close to that. So I'm doing an analysis of the cost of care in all millage programs, not just social rec, based on the utilization and then the, as Mr. Rockman used to say, the cost benefit analysis of that. Because we have to say to the county citizens, this is what you're getting for, and this is how much it's costing us. And then as a board, do we continue those things if they're adding value? Because by the way, every program we have adds value. Every program we have. But do we fund the exact same programs forever? Some we may say yes for very legitimate reasons with millage. Some we say no. And you know, my tack last year with this was to have a portion of the millage for new and innovative stuff that we haven't done in the past, and making sure a certain percentage of the millage that we have goes to that. So we did things like funding RAs at Harmony Communities, you know, so people can live in assisted living that are not in our system with autism. We funded some of that. Expanding counseling to maybe even be set up to be a CCBHC provider for us in the future. So dealing with that. Yes,
I have a question.
please.
Is the millage like a fund that people donate to, or is it like?
Yeah, well, taxpayer dollars, it's on taxes.
It's all by
Mhm.
taxes.
Yep, Ottawa County taxpayers are paying for it.
Okay.
Now, if anybody wants to donate to CMH, I can give you the address and we can take donations.
Curiosity,
Yeah.
because like
I mean it, like, so,
how it was even funded for like the millage in general, because
Yeah.
I know there's Medicaid and there's millage.
Yeah.
But I didn't know how, I know Medicaid is
yeah.
through the
So
state.
the voters of Ottawa County approved a millage, which means taking a percentage of taxes to pay for CMH services up to a certain amount, right? And it was CMH services that are in the gap of Medicaid. It wasn't to pay for Medicaid services with millage dollars, but anything connected around it. And so I'll renew and send over my little presentation to you. Is your email fixed, by the way? Because I want to say, all right, well, we got to fix it. We'll find some other way, Director Wick, and then you can review that. But that's a great question. But my job is to ensure that we keep the promise of the millage. And we need that with information. So we're kicking that process off. Why renew it? I can think of a million reasons, but we have to have a message that is based on what we've accomplished and why we still need it. Because if it's like, well, it's just to fund these cool things, well, yeah, but if you're broke, what's the tax, you know, should that be on the tax burden on Ottawa County system? That's why I fight for new revenue all the time. We are very lucky in this community that we're very giving. This is a very giving community. We have to demonstrate that the reason they give, we're keeping the trust in that. And so that's what these efforts will be doing, and you'll start seeing that. Any other questions? Thank you.
And we have a presentation this morning from regarding SUD.
Yeah, this is Joel Ebers, who runs our substance use disorder division.
Morning, Joel.
My name is Joel Ebers. I run the substance use disorder services for Ottawa County. One of the things I often say when people ask me what I do, I say I play ping pong with my email. I send an email, I receive an email, I send an email. It is because I don't get 10, 15 minutes to explain all the neat things and all the services that we get to provide. So I appreciate this time, and I appreciate you hearing me out and hearing about our programs. So if I were to sum up our programs in one statement, hopefully this works.
Technology is great when it works. You might have to advance it from the actual computer. Yeah. Remember the day with the overhead projectors? We just go, and we never had this issue.
That works. We got it.
So
All right.
we just
So if
pull it
I-
up.
If I were to sum up what we do and who we serve in one statement, it would be we offer a full array of directly run and contractual services to Ottawa County residents who have Medicaid and are uninsured. We have a little portion of like underinsured if they meet our income requirements, but we offer this full array of services. In my world, I call a full array a continuum of care. And that continuum of care looks like this. So at the very bottom, we have outpatient services. So that's just what you think coming in the office, maybe once a week. In the SUD world, we can actually extend that and up to around 8 times a week. So we can have 8 touches on a person and still call it outpatient care. And those touches could be with a therapist. Those touches could be with a case manager. They could be with a recovery coach. They could be in group. But they come in the office, we go see them in the community. That's our outpatient care. Intensive outpatient is just what it sounds like. It's a little more intensive. It's 9 to around 19 hours a week. Our programs are pretty standard in Ottawa County. They offer typically 3 groups of 3 hours a week. That's kind of what I see around is somebody comes in, they come in for a 3-hour group, or we have hybrid groups that are available, and they attend that group for about 3 hours. And then they do that 3 times a week. So it's a little more intensive, people who maybe need a little bit more support for getting into recovery. Then we have our residential. So residential in the SUD world is both short-term and long-term. The short-term is 1 to 2 weeks. Sometimes we go 3 weeks, but very rarely. And then the long-term is typically 30 to 90 days. So it's not as long as some other departments, but it's still quite a bit of time for somebody to be away from their family or away from their social circle. But it's really a chance for somebody to kind of get that restart and kind of get things back on track. And then we have what's called medically monitored residential, or it's called detox, or it's called withdrawal management. So we used to call it detox. Now it's called withdrawal management. But it's really having that medical piece in there to help somebody get whatever they're using, alcohol, maybe heroin, something like that, out of their system safely, and so that they can then move to either residential, intensive outpatient, outpatient, what have you. So, and I'll go over kind of the lengths of those stays here a little bit. So services that we offer with our directly run services. We have one of the newer departments at CMH. We hired our first full-time clinician who's doing just direct run service this year. She started it would have been April, May. She's a recent graduate from Grand Valley. So she's joining us. Her caseload is growing. It's about half full now after she got through all her trainings and all that. So, but the services that we offer is on that outpatient level. We're not that intensive outpatient. That's a contractual part, but our outpatient level of care. And so we're able to do assessments and therapy. We have some therapists that do kind of a dual role. They do the access management stuff along with the clinical work. So it's about 1.5, 1.4 FTEs that offer that clinical service. They also do a lot of case management, helping people get connected to resources. This year we began offering medication management. So we focus on that high SUD and high mental health needs. So people who, maybe a typical referral might be somebody who has bipolar disorder and they're using methamphetamine or they're drinking every day or something like that. So it's a high need for the mental health piece and a high need for the SUD piece. And so medication is often a very vital part of that. And so this year we've been able to start offering that medication management within the SUD team. So that's been a really great opportunity. And then recovery coaching. Recovery coaching is individuals with lived experience kind of walking alongside the clients as they navigate the system, as they get into community resources. So a recovery coach might attend like an AA meeting with somebody. They might take them to our community recovery center and just go play pool. They might go get a cup of coffee. They might go pick them up and bring them in for their appointments. So it's kind of filling in some of those gaps and really just walking alongside people. We also have some kind of specialty services. We have COSUP. That stands for Comprehensive Opioid Stimulant and Substance Use Site-Based Program. I had to write it down so I remember it. But really, in a nutshell, it allows us to offer services within the Ottawa County Jail. So we have a therapist, a case manager, and a recovery coach embedded within the jail. They're there every day, well, Monday through Friday, offering substance abuse services. They do a lot of assessments. We have screeners for everybody who comes in the jail. They fill out a screener that identifies whether or not the drug use is part of their life or why they got arrested, and then we follow up on that. And so that team of therapists and case managers, they screen the person, they assess the person, and identify needs. We are offering medication-assisted treatment within the jail. We don't specifically do the actual like med reviews and medication administration. That's done by the jail medical department. But we will screen the person, we'll make that referral, we'll help coordinate resources afterwards. We'll kind of do all the things that go along with that. And even through some of our grants, which I'll talk about at the end, we actually pay for those medications. Some of them are quite expensive. They can be, some of them are a shot that costs $1,000 to $2,000 a month. So we're able to fund that with some grant money.
Question for
Yeah.
you. Do you work with drug courts closely?
We do. I mean, our providers get a lot of referrals from the drug court. We fund a recovery coach for the drug court, and then our recovery coach here or at CMH, he actually is embedded with our sobriety court, and he does some recovery coaching for them as well. So we do work closely. Yes. And then one of the neat things about COSUP is that we're able to then follow that person once they get released. Our recovery coach, our case manager can see those individuals once they're released, and we can follow up with them either in our office. We can make sure they get connected to services, whether it's with us or one of our providers, but we're able to kind of help that person get back into the community. Then our SUD health home. We don't have a house in our office, but it's a place that it's kind of like a centralized hub that people can get help with coordinating all the resources around them. We have a lot of resources. As Dr. Bashir said, we are a generous county and we have a lot of nonprofits. We have a lot of things that people can access. Sometimes it's overwhelming and sometimes it's difficult to get entered into all that. And so the health home allows a health home worker to be able to help coordinate, help set some of that up, follow up with things that maybe are getting missed, and it's allowing us to gain some reimbursement for that. It's really work that we're already doing that we're able to get some reimbursement for that health home activity. It's been a slow rollout this year, and we're hoping next year that we're able to really increase what we're doing with that.
Hey, Joel, can I add something
Yeah.
to that? So I mean, the health home model itself is like you're allowed to, the additional fundings of the services that you're able to provide, it's additional funding for those indirect services that you typically wouldn't get reimbursed for. Is that
Yeah.
correct? So-
Yep. So it can be non-face-to-face. It
Right.
can be getting labs. It can be following up with a doctor without that individual right there with you. So it's differentiated from Medicaid or case management in that it doesn't have to be direct.
Right.
Yep.
And they could also be receiving services and other programs as
Yep.
well.
100%. Yep. It's a diagnosis and they have to have Medicaid. So, yep. So now on to our contractual services. And that full array or that continuum of care really shows through with our contractual services. CMH took over the SUD coordination from the Lakeshore Coordinating Council in 2015. And up until recently, we've only really offered contractual services. So this was what the base was for our substance use services. And now we've added that directly run in the last year to 2 years. And now, but this contractual portion is still a large portion of what we do. So that withdrawal management, that's at the high end now, or the most intensive. Detox, really that lasts only 3 to 5 days. So we'll refer somebody for detox, and that will, they will go there for 3 to 5 days. A lot of our providers will have that short-term right attached. So we use Bear River, they're a large provider for us. And they will go, somebody will go to detox for 3 days, and then they'll move right into that short term. So that short-term residential, again, is 7 to 14 days. We have about 3 providers that will provide that. And that's, we don't have any providers for short-term directly in Ottawa County. We have one in Grand Rapids, one actually just closed in Kalamazoo, and then we have Bear River up on the north end of Michigan. But that's that 7 to 14 days more intensive. It's really that acute stabilization for an individual. And then long-term, we have 3 providers here in Ottawa, or we have 2 providers in Ottawa County, one for men, one for women. They're longstanding providers, the Chester A. Ray Center and Harbor House run through Reach for Recovery. So they're great partners with us. And that's really that 30 to 90 days. It's a fairly intensive program. It's like 20 hours of clinical work or clinical contacts a week, but people are there, they stay there, and they get that that long-term program with those providers. Then we have about 3 providers who provide that intensive outpatient program. That lasts, again, that's about 3 times a week. That lasts 6 to 8 weeks. And then outpatient services. Some people stay in outpatient services a long time. They have like monthly check-ins with their therapists, and we're able to continue to fund that. And then, but so it can last anywhere from a short period of time to a longer period of time. We have about 5 providers that provide that outpatient care.
Joel, a question about that also, about the residential facilities. What is the ability to access those? Is it challenging? Are there waiting lists for those?
We've been able to get people into Bear River fairly quickly. So some of it depends if the person has a preference of where they want to go. If they have a preference, sometimes they can get on a wait list. Some of our wait list or some of our access is dependent on other counties and their providers. So Kent County has a lot of individuals seeking long-term, and if they had some providers close in Kent County, then they start referring to our providers, and then it slows that down a little bit. Right now, I think one of my clinicians said that Chester Ray actually has a bed or 2 open right now, so we could get somebody in today if they needed to get in. Detox we've had some providers shut down in the last 2 months. So we still have Bear River. And again, it's not that our provider network is necessarily decreasing. Our referral network, I should say. Our provider network, we did lose 2 providers, but they weren't large referring agencies. But because they shut down, then other counties begin to refer, and it slows down our ability to get people in quickly. So.
I have a quick question
Yeah.
too. Just curious, cases that come in, with parents, with kids in foster care, where they need these kinds of services, are you involved in those cases too, or is that routed a different way?
We could be. We have some programs like this family engagement team that get a lot of those referrals. They work closely with CPS, and if there's cases that need that family aspect, that's oftentimes where they go. Part of our block grant is also women's specialty funding. So that offers specialized funding and allows for specialized case management for individuals with kids or who are at risk for losing custody of their kids. So they could come into our programs, but we have programs that do have specialization in some of those things.
All right, thanks.
Yeah. Other questions? So here is some of our specialized treatment. So we have a contract with CMHOC, and they provide our recovery management and our family engagement team. Recovery management is really focused on helping those individuals who have struggled with traditional outpatient or intensive outpatient services. They maybe cycle through that residential often. They have a lot of psychosocial stressors. They're likely homeless, likely have some co-occurring issues going on. And so it's really an intensive service. It's a community-based service, and they're going out to track people down and to help provide services. And then our family engagement team, that's a specialized team that works closely with CPS. They work with families who are at risk for losing their kids, and it's really an intensive family model. And it's, again, can be community-based, and it allows for just a little bit higher level and more specialized care. And then we do have some providers that provide methadone. Methadone's a daily dosing prescription that people can take to help curb with cravings and for opiates. And we have two providers, one in Granville, two providers at two locations, and then one provider in Granville who provide that service for us. So that's another specialized service for.
Joel, are we using Suboxone treatment at all?
Yep.
And what is the differential in terms of how a decision is made to use Suboxone versus methadone?
We do. So usually methadone is seen as kind of the most intensive medication. If somebody is on Suboxone or they're using very, very high doses of either heroin, opiates, any kind of opiate, they're going to maybe be more likely to look at that methadone because that's what's going to really help them in that craving aspect. Whereas if somebody isn't using quite as much, or maybe they take Suboxone, they're like, yes, it's working for me, they might be able to do Suboxone. And we have, most of our providers do offer the Suboxone.
Okay.
Yep. And we've, 5 years ago, it wasn't that way.
I know.
Yeah, it was really difficult to find. And, but now primary care, CMHOC, REACH, they both are prescribing Suboxone. And I mean, methadone, it's difficult for people to get there every day. It's a daily dosing,
Right.
and that can be difficult. But sometimes people take the Suboxone and they just, it doesn't work for them.
Okay.
And I mean, that's up to really the prescribing physician and that individual. So
Appreciate that.
yeah. And with Suboxone, they're coming out with more. The Sublocade is a 30-day injectable. That's basically Suboxone. That's injectable, and then Vivitrol is something that just helps with cravings, and that's also a 30-day. So there's starting to be other medications that outside of just methadone and Suboxone.
Good.
So some of these, alongside our clinical treatment, there's recovery support services. So these are really just services that enhance. A big one is recovery housing. We have a large provider here in Holland called Building Men for Life, and we partner very closely with them. They house anywhere, they're not all Ottawa County clients, but they house anywhere from 70 to 100 men in their houses at any given time. So a lot of guys find that they enjoy the support. They begin paying rent on their own. They're working, so that, I mean, they're sustaining that on their own, but it's within a Building Men for Life house. We fund the first 2 months, and we will do that in conjunction with treatment services. So somebody has to be engaged in treatment, then we will help fund their recovery housing. So it's not, we are not allowed, it's a block grant funded rule. We're not allowed to fund the recovery housing without that treatment in place. So they kind of go together. We have 2 women's providers. We have 70 by 7 and then My House Ministries here in Ottawa County. And then we have Recovery Road in Grand Rapids. Recovery coaching is really something I see as a great benefit to any level of care. And we have 2 recovery coaches. Well, in the SUD program, we have 2 recovery coaches on staff that do a lot of outreach for us. They do a lot of kind of filling in all those gaps. And they really provide that support from that lived experience. So what about the numbers? So just with our numbers, this goes back to 2018. You see we're right around, it's kind of hard to read on the screen. We're right around between 900 and 1,000 admissions within a year. Admissions are kind of a funny number because we can admit somebody into detox for 3 days and then admit somebody into short-term for a week and then admit them to long-term for a month. So that's, admissions isn't a great way to see how busy we are. I'm learning our new system and I'm learning how to pull reports out of it. So I pulled an authorization report and we had around 455 active authorizations right now for services. Some of those are recovery housing. So in my social work math, I'm going to say we have about over 400 clients right now. But I'm sure I'll learn our new system and be able to pull some exact numbers. So 400 active clients right now within that directly operated and contractual level of care. We have 10 full-time positions within Ottawa CMH. We have 3 partial positions. They're not really part-time, they're just shared with other teams. That includes our prescriber, our medical assistant, and our support staff. And then we have 18 contractual agencies at 28 different locations throughout mainly Ottawa County, but throughout the region and state. So this has been a project that we've been working on. This was a partnership with Building Men for Life that then what is now what's called SOBAR Community Recovery Center. And this is really a place for people to go to find community, to have fun, and to really meet others within recovery. And this has seen more growth than I ever thought it would. So here's some pictures inside. This is actually an old church that was an architect firm that is now back to like a gathering space. We've been able to help with grant funding to help renovate this space and get it looking like it is now. So you could see it's just some spots for people to hang out and spend time. What I wasn't able to get a picture of, because there were some people there, was kind of the meeting space and some areas for like recovery support meetings to meet. So this year, SOBAR, even with the move and the renovation and everything, they've had over 6,600 sign-ins into their facility. They have like a check-in procedure. They have 222 people who are registered within their check-in system. They just in August, so this renovation happened over the summer, just in August, they've already had 651 check-ins by people. And then they also offer 13 like recovery support meetings throughout the week. And they've had over 3,900 people participate in those support meetings. So it's really, I see this as a really great community asset and a great option for people. A lot of our staff will go there and meet with people because it's a neutral environment for them to meet with. The picture in the middle, if you look way in the back, not the door facing us, but the last door on the right, that leads into our new location. So that's that door on the left there. So we've been able to lease a portion of that, and we'll be moving our team in as soon as we get internet. So we have a space there that we'll be able to integrate with them, be a little more accessible. And so I'm excited about that. This is kind of the front desk, standing with my back to the front door. And then this is at the other end. So we have about 5 offices there that'll accommodate our team and be providing those directly run services. So that's our treatment side. We do have went too far. We do have a prevention specialist on staff. The prevention specialist coordinates things like the medication takebacks event, Recovery Fest, which I'll talk about here in a sec. Overdose prevention trainings. We've really seen a huge growth in the overdose prevention trainings. We've trained 95% of our staff. We do trainings at some of our residential facilities. We've done them at Grand Valley. We've done them at Hayworth, Miller Knoll. We've really partnered with the community to help people understand how to respond if an overdose were to occur. And then part of the prevention specialists' charge is to help just increase knowledge of how to access treatment, what treatment looks like, and things like that. So we have Recovery Fest coming up on September 11 from 3 to 6 at the Holland Civic Center. And I have a video I'd like to show. It's just a short, like less than 2-minute video, but it's a recap of Recovery Fest last year.
Addiction and substance use is very isolating. There's a lot of stigma that comes along with it. When you feel that you're not alone, it does wonders for your mental health. And so we want to connect people who are struggling, who have had successes with other people. Recovery Fest is a celebration of all things recovery. We like to highlight the successes that people have had in recovery and show people that recovery is fulfilling and fun. It's an event that is for everybody, young and old. It's not just about those in recovery, it's about people who care about those in recovery. It's about those people who have walked alongside people in their journey of recovery. We want to show that there is a community of people in recovery that live their life to the fullest. We want people who are on the fence or unsure about what recovery is going to look like for them feel welcome. We want them to see that there's a community, there's support, there's resources. We have vendors come from all over the community with all different types of resources. Housing, overall health, support groups, treatment. They give examples of what the journey of recovery is going to look like, what options are available, different avenues that you can take, because recovery is different for everybody. Just because your life's changing doesn't mean that's a bad thing. Your life can be so much more fulfilling in recovery, and when you overcome things like substance use, it's like living for the first time.
What's the date of that again?
September 11, 3 to 6 p.m. And that's an event that's been going on. It used to happen in the park downtown, and it's moved to the weather has caused us to say, let's find an indoor space to do that in. So the person talking there was Daniel. He's our recovery or our prevention specialist. He's on the planning committee for that, and he does a lot of great work with that. And that video was put together by our county media or person, so he did a great job with that. We could go again. There it is. And just to kind of go over our funding sources, we're mainly funded with Medicaid. That covers a lot of our clinical services, a lot of those medically necessary services that we provide. We have block grant that then helps with anybody who doesn't have insurance. Block grant and general fund are very similar. We have PA2, which is actually a local dollar that we have a lot of discretion over, that we're able to use for local treatment within Ottawa County. PA2 has been used to help with SOBAR, and to help with getting recovery coaches into places that maybe Medicaid can't pay for, like some of the outreach, homeless outreach and things like that. And then we have some grants and kind of special projects. We have what's called a state opioid response grant that's helped pay for some of our medications within the jail. We have a healing and recovery community engagement and infrastructure grant that helped pay for some of those renovations. That's actually opiate settlement money that is stayed at the state and then is funneling down through the LRE. We have our COSAP grant, which I talked about earlier. And then we do have some money to provide tobacco cessation, and our recovery coaches provide groups for that. So really quick overview of the money, but I appreciate the time. If you have any questions, I'd love to answer those.
Yeah, I'd be interested, and maybe we can take a closer look at this in the PQI committee about like outcomes measures and what that's looking like, that data. I know that you have some requirements from the state that you have to report.
Yeah, we can definitely look at that.
I don't have a question. I just want to say, God bless you. Thank you so much for this. This is a great presentation. Just to piggyback on Mr. Bird, my husband does run sobriety court at the Grand Haven District Court.
Yeah.
And, I work with people with autism and cognitive impaired every day. And I find that hard, but I think what you do is really hard, where my guess is like 3 steps forward and maybe 4 steps back. And I listened to some of the stories, no names, of course, but I listened to some of my husband's stories. And I think the greatest days, and I've sat in on 1 or 2 of the sobriety graduations, to watch a family watch their loved one come out of all the different treatments, like just, it's amazing. And those are my husband's favorite days, when he comes home to watch someone successfully, no matter how many months or years it's taken them to get to that point. So just thank you, Joel. This is really good stuff. Thank you.
Well, and the thanks really should go to the team, because they're the ones
100%.
doing it.
It
And
does take a village, doesn't it?
we have a great team, and
Yeah.
they do great work.
Well, thank you for what you do.
Yeah. Other questions?
Not a question, but I also just kudos to what you guys are doing. And I love what's going on with SOBAR and the excellence of that building. I just love that you guys are providing such a beautiful space. Just that in and of itself gives hope. And so I'm just thankful you guys are doing things with such excellence.
Yeah. Yep. They've done a lot of it has been volunteer, and it's been awesome to see. And people like even heating and cooling, they donated a lot of their time, and so we've been able to do a lot of things with not a lot of money. So it's been cool.
Very cool.
Volunteer is the best,
Mhm.
Yep. Well, thank you for your time.
As I recall, that is on the Max bus route, right?
Yep. It's right there.
So just one more question. So then you said you're moving some staff in there. Is that going to become your primary location then?
That'll be our primary location for our SUD services. Yep.
Okay.
We'll work out of there.
Okay. Will you have anybody any place else, or is that pretty much where it is?
We'll be able to come to James Street. We do see a few people in Grand Haven too, so we have some flexibility. But that will be kind of the primary location for that team. If it continues to grow, we could look at other locations. For so long, we've relied on contractual providers, and they're up in Grand Haven. We actually just got one in Allendale, so that side of the county's or Jenison, I'm sorry. And so that side of the county now has a provider in it. So we have providers that provide the services. If we continue to see the population that we want to target grow and that need be there, we could look at other, like working out of Fulton.
Okay. So just one more question then, for people listening. What is the location of the SOBAR?
It is 347 Hoover Boulevard. So it's right by, there's a Culver's going in on the corner and it's right behind there. So kind of right by that busy intersection by Menards and 16th Street.
Okay, and that's Holland, right? Then
Yep,
Holland. Okay.
yep.
Thank you.
Thank you.
Thank you.
So,
Just want to remind the board that you approved the use of millage and things for SOBAR and the grants, so thank you as well.
Okay, there is no old business on the agenda. New business, we have some contracts, Michael.
Yeah, reason why this is there is that the Finance Committee did a good job in approving all of our amended and renewed contracts. What we realized is that one of them actually was what we didn't think what it was. It's actually a new corporation that was formed, and not just extending a location for one of our providers. They actually created a separate entity to provide the same service, and that's the Gibbons. Let me just pull it up here. And so technically, the Finance Committee approved something that wasn't actually, it needed to be a new contract altogether. So I decided, what we ended up doing is when you approved the consent agenda today, for those, we actually had crossed out that thing in there, if you saw that in the packet. And the new action that's required is it's a new contract for residential services, expanding our service array. And because this provider created a separate LLC, corporate counsel told us we need a separate contract. It can't just be expanding the old one. And so that's what this is. So it was approved as a renewal, but it really needed to be a new contract. So I have it for your consideration and approval, and it's to expand the provider panel for residential services. And that's what that is.
I'll move to approve.
I'll second that.
Any further discussion? Not, we'll do roll call vote.
Dr. Duff?
Yeah.
Yes.
Yes.
Dr. Faulkner? Yes. Yes.
Yes.
Yes.
Yes.
Yes.
Yes.
Yes. Motion carries. Thank you.
And then on the review and scopes, my intention is to forward the description that I've put together to the executive committee for consideration of the full board. So I will do so if that's an agreed upon course of action by this group. And what this is remember, we were asked like, hey, what is the role and scope of the committee or the well, not subcommittees, the committee role for the finance and performance and quality improvement. And so I've put that together, and then I thought procedurally I'd have the executive committee take a look and then recommend adoption by the full board. So it's at this point information to say what I intend to do, but Director Duff wanted this done, so I have to make sure we have that process, and I anticipate we'll have that on the September's agenda for approval after the executive committee has taken a look at it. That's kind of what I want to do with that. Because it will change, it will make us change our bylaws, our board bylaws and descriptions and how we do things. And when that happens, the executive committee is charged to look at that first and then make recommendations to you, the rest of the board, for approval or not approval. I don't want to be the one as your employee to say, here's how it should go. But I'll give you my thoughts in terms of the scope. I'm using the mental health code and the intention function of those committees for consideration for the board to consider. But I want the executive committee really to be the one that brings it to the full board for approval. I think it's inappropriate for the executive director to do that or the CEO to do that.
Does anyone have any objection to having our executive director follow through on that? If not, we will assume by consent that you have our request to do that.
Thank you.
Did you have anything else?
No, I don't.
Okay. General information, comments, and meetings attended. Before I ask for the other board members' input, I will mention that the executive committee did have a meeting with our executive director to go over his annual review. His contract does call for an annual review by the board prior to November 1st. With his anniversary date being the end of July, we went ahead and did that process. Thank you all for the board members who responded to the survey which was sent out. And as I alluded to earlier, this was done anonymously. Even I don't know which comments individual board members submitted or which ratings were given. We wanted to do that to provide an open and free environment for information to be provided. I can tell you that in every one of the categories, the ratings were a 3, 1, 2, 3, 4, or 5. A 3 means you're fully meeting all of the requirements of the job. And frankly, if a person got a 3 rating in every category, we'd say, great, you're doing a good job. Well, it turns out a 4 means you're exceeding requirements, and a 5 is you are exceptional. And in every category, our executive director scored over 4, and the aggregate composite number for everything combined was 4.78. So obviously, we are very well pleased with your performance, and the executive committee is grateful for the time you spent with us discussing goals for the agency, and we'll look forward to further presentation of those as we go forward. Thank you. And I think a round of applause is. Anyone else on the board have general information or comments or meetings attended? Okay, we have another opportunity for public comment if anyone would like to speak. Do we have anyone online, Amanda? No. Okay, then we will, absent any objection.